Thank you for the introduction. So some of you might wonder why a person who spends his life treating a patient with diabetes is talking about lipids. And the answer is very simple, is that 80% of my patients die of heart disease and stroke. And therefore, we have to do it. The other point is no one else seems to be interested in this university on it. So I sort of became the de facto. So I will tell you, my disclosure, I am not a trained lipidologist. It's all self-trained. I'm kind of a pseudo-lipidologist, but I do my best. So the main objectives for today are talk about lipid abnormalities in diabetic macrovascular disease and premature coronary vascular disease, talk about the pathophysiology, diagnosis, and management of dyslipidemia of diabetes and the metabolic syndrome, talk about prioritizing goals for CV risk reduction in people with diabetes and other related disorders, briefly review dietary and pharmacological strategies to achieve these goals. So Elliot Joslin, the famous diabetologist, said many years ago, genes load the gun, lifestyle pulls the trigger. So if you look at heart disease, with the NHANES data starting in 1950, you can see it was 1,000 deaths per 100,000, and it has come down, but it's still the #1 killer. Cancer hasn't changed, stroke has gone down, and so forth. I think you're aware of that. So what's really changed? So if you look at NHANES again, each one is a decade. So in the 1960s, people with a total cholesterol over 240 was about 35%. Now it's about 17%. Hypertension, people with systolic of 140 more, diastolic over 90, was about 30%, now about 15%. Smoking has been cut, not enough. It's gone from about 40%, 45% to 26%. But what's happened, of course, is diabetes and obesity has come up. So this diabetes figure of 8.3% is a little bit out of date, and it also depends on the state. So the worst state for diabetes, by the way, is West Virginia with 13%. Mississippi is #2 now. However, I will tell you that the counties of Eastern North Carolina have incidence of diabetes of 14 to 15% or more. And so the diabetes fueled by the obesity epidemic is what's causing this problem. So here's a question for the House staff. At what age do the early pathological, not clinical, manifestation of atherosclerosis begin in the United States? 2 to 15, 10 to 18, 18 to 36, over 30, over 40. Anybody know? Want to guess? Any residents? Resident. Well, the answer is 2 to 15. And here's the Bogalusa heart study. This was a study of children and young adults who died with things from car accidents, homicides, and so forth. And you can see at 2 to 15, when they studied the coronaries very carefully, there was about 20% incidence of aortic disease and about maybe 10% incidence of coronary disease. But I want to show you the 21 to 25 group here. So the incidence of aortic disease was 30%, but the incidence of coronary disease, we're not talking about clinically significant, but some coronary disease was 50%. So probably everyone in this room has some coronary disease unless you're a vegetarian or have really, really good genes. So in this Bogalusa study, they found many of these children were extremely obese. Some had hypertension, some had high cholesterol and triglycerides, and some were smoking as well. Here's the next question. Which condition leads to the highest death rates worldwide? Smoking, high cholesterol, diabetes, prediabetes, obesity, or smoking marijuana? And the answer is cigarette smoking, #1 cause worldwide. So it was estimated that smoking contributes to almost 5 million deaths, cholesterol about 4 million deaths, diabetes about 3 million, and obesity 2.5, but obesity is moving up fast, so that may be even higher later. So Dr. Joslin also said, with fat, diabetes begins, from fat, diabetics die, formerly of coma, and more recently of atherosclerosis. So looking at the deaths due to diabetes, you can see that it has gone up dramatically, where in fact cancer deaths have been level, and there's been actually overall a decrease in cardiovascular deaths. So as I mentioned in the first slide before, with NHANES, cardiovascular disease have decreased, and stroke has decreased. So 80% of people with diabetes, type 2 specifically, die from cardiovascular disease. And it's also told in some of the studies, when you're newly diagnosed with type 2, 50% of the people already have heart disease. So this is an interesting thing and a very sad thing. So women, as you know, normally have a hormonal protection and get coronary disease at least 10 or 15 years later than men. But women with diabetes are a very different situation. They have lost the cardiovascular protection. So in the last 30 years, there's been a 27% decrease in heart disease in non-diabetic women, with a 23% increase in women with diabetes. And the risk of an MI in a diabetic woman is 3 to 4 times that of a non-diabetic woman. So this is a really significant factor driving up coronary artery disease in this country. So many years ago, Dr. Hafner did a study called the East-West Heart Study. And they looked at people for myocardial infarction over 7 years. And the people that never had diabetes and never had a prior MI had about a 3.5% incidence over that 7-year period. The people with diabetes with no prior, with a prior MI rather, and no diabetes, so they've had one heart attack, now they have a second heart attack, but they're not diabetic, had about a 19% chance, 1 in 5 having a second heart attack. The people with diabetes but no myocardial infarction, no prior heart disease clinically, now had about a 20%. And of course, those with diabetes and a prior myocardial infarction had the worst 45. So because the 19 and 20 are about the same, the American Heart Association came out at that time saying that diabetes is not a risk factor of coronary artery disease, it is an equivalent of coronary artery disease. Now, some people have doubted that, and here's a study which seems a little different. Now, this is not, so the last study was incidence of an MI. This study is death. So Kaplan-Meier curves, the ARIC study. So these are people with dying from heart disease over a period of about 11 years. So no diabetes, no MI, about 4%. Diabetes and no MI, about 11%, but no diabetes and MI, about 19%. So there is certainly a difference here, but still, this is significant. And again, coming in the last place, diabetes and MI, about 32%, about a third of them die over 10 years. So I could give a whole talk on this concept. That's improved glycemic control, decreased cardiovascular mortality in patients with diabetes. And this has been controversial. We'll talk more about it in maybe another lecture. But some studies, such as the EDIC study, which was a follow-up of DCT, UKPDS, the EPIC, STENO2, and the VA study in the first 15 years, did say that you catch people early in the course of disease, glycemic control is helpful. Late in the course, it may not be, such as ACCORD. So the VA study, for example, they had less than 10 years of diabetes. Their reduction with better control occurred. 10 to 15 years was a wash. More than 15 years, they actually had more. So that basically supports the legacy effect. And if you get people in control early with type 2 diabetes, you may have a better chance of preventing. But the rest of that, most of the people, we have more have to worry about controlling lipids, blood pressure, weight, and stop smoking. So this is probably pretty known to you guys, a brief review of atherosclerosis. And here's a tombstone of John Doe, who died of a bunch of stuff. We don't have much. But if I put the Bojangles menu on that, that would probably be pretty good. So what did he die of? Of course, we all know he died of a coronary thrombosis here, shown here. And here's, you can see a myocardial infarction, 1 week old. You can see that tissue over there. And then here's the thrombosis of the coronaries, and here's the ruptured plaque. So this is what's going to kill most of us in this room and most of our patients. So here's a normal coronary artery. Here's one obstructed with plaque. And we know the concept of the vulnerable plaque that is patient. So really the diameter of the blood flow may not be as important whether that what the plaque is made of. If there's more fat in that plaque, you're more apt to have a coronary thrombosis. And this slide just shows you the time course. So when you start off, these are the Bogalusa heart study we discussed. So here you have little fatty streaks in young people, but eventually the fatty streaks get worse, become plaques, become atherosclerotic plaques, and they may actually get angina or claudication. And here then, of course, you get the plaque rupture, fissure, and thrombosis, leading to an event, ACS, unstable angina, heart attacks, death, stroke, critical limb ischemia. So John Guyton, who was our speaker a few years back, he made a very important point, and that is the intima, the arterial intima and the coronary arteries does not have lymphatics. So therefore, it cannot clear away these molecules. So LDL, therefore, concentrates 10 times higher than other connective tissue. I think that's a very important point that people don't always appreciate. So we'll switch gears again. I know I have a very extensive menu of topics to talk about today, but I think, I apologize for going fast, but I think it's important to go over them in detail. And here's the doctors as a patient. There's good and bad cholesterol. We've gone to the dark side. There was a cardiologist here many years ago named Andy Sumner, who was he was a lipidologist, and his talk was called The Good, the Bad, and the Ugly. The good meaning the HDL, the bad meaning LDL, and the ugly meaning the dyslipidemia of diabetes and the metabolic syndrome. So everyone knows, there's some debate whether you really need to fast patients, because there's some thought that postprandial triglycerides and free fatty acids actually are more predictive, but let's forget that argument. But typically, you're supposed to fast people 9 to 12 hours, no alcohol for 24 hours. But in a non-fasting state, you can still measure a lipid panel and get the HDL cholesterol and the non-HDL cholesterol. We'll talk about that. So if you really want to know the LDL and they're not fasting, or the triglycerides are over 400, in which case the indirect method doesn't work, you can just send off blood for a direct LDL. Direct LDL is actually very accurate. It is somewhat expensive. Or you can, of course, do the test to look at the non-HDL cholesterol, and you can calculate that. And to calculate the non-HDL is basically the total cholesterol minus the HDL gives you the non-HDL. So this looks at, so you have to remember that lipids basically don't travel themselves. They're like people that can't swim. So to get it, for them lipids to go places, they have to be hooked up to a lipoprotein. So think of the lipoprotein as the boat and lipid as the passengers, and the apoprotein tells the boat which port to go to. So if you look at if you look at the densities, you have the highest densities here, low density Lp(a), intermediate density, VLDL remnants, VLD, and then chiromicrons are the largest particles, the least dense. But basically, if you take out the HDL, everything else is atherogenic. So everything else is your non-HDL cholesterol. And there are many medical conditions that we see commonly, including diabetes, thyroid disease, for example, renal disease, use of steroids, that all cause dyslipidemias. I will mention the point about diabetes. When diabetes is poorly controlled, people come in the hospital and they have an A1C of 12 and their cholesterol is 300-400, their triglycerides are several thousand. They have the so-called lipemic syndrome or chylomicronemic syndrome, and they have this, basically their plasma is all, looks like cream here. They may have ruptus xanthomata, and they may actually have that tomato soup fundus because it's basically cream circulating in their plasma. So, and one of the most important points is these patients have a low HDL cholesterol. So low HDL cholesterol encourages diabetes, metabolic syndrome, people with high triglycerides, obese people, insulin active, smokers, and people on high carbohydrate diets, and I'll get back to that. That's a very important point. So now I'll change gears again and talk about the metabolic syndrome, sometimes called the deadly quartet, with insulin resistance in the middle, followed by diabetes, hypertension, obesity, and dyslipidemia. So there's controversy. Does a metabolic syndrome exist? I certainly believe it does. It's defined in the U.S. by people with a waist circumference over 40 in men, over 35 in women. However, in Asians, it's like 35 and 32. A triglyceride over 150, or HDL less than 40 in men, less than 50 in women. Hypertension or prehypertension, or diabetes or prediabetes. And if you have any of these three, you consider to have metabolic syndrome. So really almost everyone in this audience who's in medicine, this concept affects people. If you're a cardiologist, you worry about atherosclerosis. You may worry about dyslipidemia. The GI people worry about hepatic steatosis, which goes on to cause alcoholic fatty liver disease, cirrhosis, and even liver cancer. The dermatologists see people with acanthosis and skin tags. Rheumatologists see the people with gout. The gynecologists and some of us in endocrinology see people with polycystic ovarian syndrome. Everybody sees people with obesity. We see people with diabetes, and hypertension seen by most of our general medicine. So really, insulin resistance is, and actually the concept of insulin resistance was developed by Gerald Raven at Stanford, who noticed that people who were hypertensive also had insulin resistance. And so this is the West of Scotland study, with the primary prevention study. And you can see that the more components of metabolic syndrome you had, was a dramatically increase in your risk factor for new onset diabetes. And likewise, the more risk factors you had, was increase your risk for heart attacks. Here's another question, and my fellows have seen part of this. We won't ask them, but everybody else. Who do we resemble more, the dog or the rabbit? Anybody? Rabbit, right. We do. And we do resemble the rabbit more because we have dull teeth, not sharp teeth. We don't have claws, although some of you have long fingernails, I guess. But the biggest difference is the intestine. So if you feed a dog or a cat, for that matter, all the fat you want, they may get obese possibly, but they won't get atherosclerosis because they have a short intestine and all the fat goes out. But if you feed that to a rabbit, that rabbit will get atherosclerosis. So actually, this is a very interesting thing. Dr. John LaRosa is an expert in lipids in New York, and he says, quote, "Our dental anatomy suggests we are not meant to be meat eaters. Animals that eat meat have sharp, tearing teeth, while we have flatter teeth more similar to vegetarian animals. He goes on to say, chimpanzees don't eat meat. They eat very little fat. Their LDL levels range from 40 to 70. They don't get atherosclerosis. Levels of LDL below 70 are on par with those of non-human primates who don't develop atherosclerosis. Like those primates, humans were designed to be vegetarians. Maybe humans wouldn't get atherosclerosis either if we had levels this low. So you've probably seen these slides before. We evolved from a hunter-gatherer. So in the hunter-gatherer days, basically during the summertime, or if they live in Africa, most of the time they could always get things growing off the ground. But once winter set in, they had to rely on the man to go out and hunt and kill something like a wild boar. They would bring it home. He'd eat it first, then he'd give it to his mate, and then the kids and the grandparents in that order. And it turned out that people who could basically, so the concept of being able to eat meat and also to make fat and store fat led to survival. So basically our ancestors who could store this fat and save it, then when there was nothing around, they would live longer. And you know obese people who are starving live longer than non-obese people. So women who could gain this weight, was a survival thing. However, that gene doesn't help this guy here, who's a football fan, with a BMI of 40, asking his wife to bring him more potato chips. And he's watching TV. So that's what we've evolved to. And so there is a theory which I think is true. It's called the thrifty gene hypothesis. And that is our ancestors with intermittent starvation and a high protein diet. Remember now that the meat that people ate is sort of like eating, if you go eat venison, for example, there's hardly any fat there. Those of us who eat roast beef, you know that cow is raised on grass, then is sent to some little stockyard in Nebraska, put in a little pen, fed corn, so it gains another 150 pounds. And then, of course, you know, they serve that cow with roast beef, which tastes delicious. So we eat the roast beef, we eat the hamburgers, and of course we get atherosclerosis, we die. So I guess it's only fitting we kill the cow and the cow kills us. So the concept is intermittent starvation, high protein diet, and also you don't have, I mean, how do we get our food today? We'll say, oh, I'll have 2 Big Macs and order fries, and you're still in the car ordering the thing. I mean, you should see the line of cars at Bojangles in the morning. It's unbelievable. So we don't do any work to get that food. So then this suggests, so anyway, our ancestors gave us this thrifty gene, which is a thrifty gene that caused insulin resistance. But now we take this and put it in an environment where people don't get physical activity. People eat huge amounts of food, huge amounts. And we can talk about diet later, but eating things that are not healthy, and of course, now this gene that used to help us is now hurting us. So if you look at the metabolic syndrome, for example, in this study, half the population didn't have metabolic syndrome or diabetes. Their incidence of heart disease, their prevalence rather, was 8.7%. Metabolic syndrome, no diabetes, was about a third of the population, 30% or so, and they had about 14%. Diabetes, no metabolic syndrome is very uncommon, only about 2%, and their incidence of heart disease about 7.5%. But again, the same thing like we said before, diabetes, metabolic syndrome, they have the worst, about 19%. So when you look at the factors that metabolic syndrome incorporates, not only does it have obesity, inflammation, dyslipidemia, diabetes, and all the atherogenic diet and activity with atherosclerosis, but a very important point is that dyslipidemia includes lipids being deposited in the myocardium, which leads to heart failure. So it's very common for people with diabetes, obesity, metabolic syndrome to have this situation because of the ectopic fat put in the myocardial cells leading to heart failure. So another concept that's very important is that visceral fat is metabolically active. You've probably seen this before. This is a CAT scan of someone who's normal. This white represents a visceral fat. There's a little bit of subcutaneous fat. And this person has much bigger, there's a lot more subcutaneous fat, but has a lot more visceral fat. And if you ever did autopsies on people that are very obese, you know all that fat is in there. And so this fat is really the important fat. So if you look at these two people, this guy here has a huge rear end, and he's sitting on a fire hydrant waiting to get in the Cubs game. Of course, the Cubs never win anyway, but he's sitting right here. This guy has the Milwaukee goiter, if you will. It's a big obese person with a bear belly. He's the one that's going to end up with the heart attack. So having big rear ends and a big thigh is actually not pretty, but it's a lot healthier than having that beer belly. Because the beer belly, the fat in your abdomen, is metabolically active. It's associated with inflammatory markers. It makes less adiponectin, increased cytokines, increased free fatty acids. So here's some fat tissue, and you can see what happens is that the fat itself can make leptin, adiponectin, pi-1, but then when the macrophage embeds itself in it, it also can make TNF-alpha, IL-6. So basically, we have this metabolic fat or visceral fat that's around in the intestine, and this is the fat that predisposes people to type 2 diabetes and to heart disease. So we had, for our first lecture many years ago, Dr. Scott Grundy, and he had a very important concept, and that was to understand the relative adipose deficiency, how that affects people. So there's a condition that Dr. Dar sees in our clinic, and that's a lipodystrophy syndrome. Also, HIV patients have lipodystrophy at places. So basically, when you have atrophy, this person looks like they work out, but they don't. Just they have no fat. All you see is muscle. So you have almost complete deficiency of adipose tissue. And they have terrible metabolic problems, severe insulin resistance, hypertriglyceridemia, and they also have hard to control diabetes and very high lipids. So think of this as a model for a second. Now let's look at that model compared to us. So here are obese women and obese men and people with the FPLLD syndrome. So the blue is the lower body fat. So you can see, as opposed to men, women have much more lower body fat. The amount of upper body subcutaneous fat is about the same. So therefore, women have more depots and they have less visceral fat than men. And they have less ectopic fat than men. So that actually is one of the main reasons that women have better survival, except of course if they have diabetes, in terms of heart disease. So when I say ectopic fat, what do I mean? Ectopic fat means that the fat ends up in your muscle and causes insulin resistance. The fat ends up in your liver and you end up in the GI clinic with NASH. The fat may go into beta cells, and then if that fat goes into the heart, you have myocardial dysfunction and you're in the heart failure clinic. So the way I like to think of it is with an analogy. So let's say you have two people who have the same size house, but one person has a huge closet and one has a small closet. And let's say, like my wife, they get about 30 Christmas catalogs every day, and they don't like to throw them out. So pretty soon the person in the small closet has the closet filled. They can't get another one in there. So now what happens? The catalogs end up in the living room, in the bathroom, in the kitchen, right? All over the house. So where the other guy may have just as many catalogs, but you don't see them out of sight. So the concept is, with this analogy, is people such as Asians, for example, have very small closets. I treat many people who I would wish to be that thin, that are Asian, from India, other places in Asia. They have just a little bit of belly, but they have the same amount of diabetes. When I was in Korea lecturing last summer, they have 5% diabetes. They don't have obesity. I was in a mall for 2 hours. I saw one obese Korean person. Unbelievable. So clearly, so it's different. So we in America have the advantage. Americans have the advantage of having more sub-Q fat. So if you see people with a big thigh and big rear end, say it's not pretty, but it's healthier than having the beer belly. I mean, this is very important. So now the sixth great explanation how obesity causes cardiovascular disease, it raises insulin resistance, high free fatty acids, and increased VLDL, but then that VLDL can go to become increased small LDL or decrease HDL, and it gets called cardiovascular risk. So what happens to the VLD and ApoB? Well, so some LDL is actually okay. It becomes a more buoyant LDL. But in the face of hepatic lipase, and then in the face of diabetes and metabolic syndrome, this VLDL then converts to smaller dense LDL particles. And the problem there is they're oxidized. When they're oxidized, they're taken up by scavenger receptors and macrophages. As we showed you earlier in the fat cell, those macrophages take them up. They form foam cells, and then they end up as fatty streaks, going back to the Bogalusa heart study, and all of us having fatty streaks. So that is a concept. So the good, the bad, the ugly in terms of diabetic dyslipidemia, or that of metabolic syndrome, is defined as a high triglyceride and a low HDL. And then the LDL is usually normal quantitatively, but there's more LDL particles and small dents. And of course, going along with that is increased ApoB and then increased non-HDL cholesterol. So if you have two people with an LDL of 100, but one has more small particles, 70% more smart particles, that's a problem. Because LDL, so if you just measure LDL cholesterol, not particles, this undervalues it. And you don't realize this patient's at much greater risk for heart disease. So this is a study looking at HDL and triglycerides and LDL, and it's kind of complicated, but the point of the matter is the cardiovascular risk correlates much, much better with LDL particles than it does with any of the other measurements. So we do use a lab called LipoScience in Raleigh, and we send out this analysis for particles, and it's sometimes very, very helpful. And it actually has, you can look at insulin resistance. There's a lot of things, I think, in particles that are useful. Now, if you don't want to spend the extra $50, you could do the non-HDL cholesterol, which is basically a free test. So what about risk assessment? The doctor says, well, your cholesterol is the same, but your research findings have changed. When I was a medical student, we were told normal cholesterol is below 300. A systolic blood pressure was your age plus 100. So if 60 years old, 160 was normal. And a blood sugar, anything below 200 was normal. So it's all changed. And we now know more stuff. And we'll talk about what is really normal. So risk factors include your age, men over 55, women over 45, smoking, hypertension, low HDL, and a family history of premature heart disease in males less than 55, females less than 65. So when you assess a patient for lipids, what do you want to do? You want to look the patient over, and I believe in examining patients without their clothes, putting a gown on them, and actually looking at their skin, listening to their heart and lungs, not using it through their clothes. Anyway, that's sort of a thing I think is important. But anyway, many times you find things, and you can find xanthomas on patients, and xanthomas can be a clue. So now arca senilis is pretty common, but if you're under 50, it may actually be a sign of high cholesterol, where at over 50, it's considered to be, quote, normal. You can have plaques on the eyelids, which actually predict cardiovascular disease. And you can have xanthomas. These are tuber eruptive xanthoma, which are classic for type 3 or remnant removal disease. So it's important to look at the patient for xanthomas and to do the cardiac risk. You can do the Framingham risk, which has been around for a long time. The only reason I don't like Framingham risk, it doesn't include diabetes. And again, as I mentioned before, type 2 diabetes is considered a risk equivalent, as is people with carotid disease, aneurysms, PAD. So all these things are considered cardiac heart disease equivalents. So I mentioned what normal cholesterol is. So I'm sure everyone in this room knows their cholesterol. But if you're between 150 and 200, I think I'm doing pretty good. Well, actually, you're not, because in the Framingham data, 35% of people with cholesterols in that range, below 200, still had heart attacks. So I'm waiting for the new classification. But they're still saying, well, LDL should be less than 100. But I don't agree with that. Here's my friend Barbara Howard's data. And if you look at people with LDL of 98, they still had a 37% increased hazard ratio. Only when you get down to 70 or less does the ratio go to 1 or less. So management strategies. So here's a close-to-home cartoon. The doc says the plaque buildup in your arteries is so severe, I brought in a specialist, and here's a rotary guy. So, all right. So we could talk about studies, lipid studies, clinical trials forever, but there's two basic varieties: primary studies, primary prevention, and secondary prevention. I'll just talk about a couple. The 4S was one of the major studies showing simvastatin had a 55% risk reduction, and the subgroup of diabetics, it did very well. And the CARD study said basically, the bottom line with the CARD study that starts for collaborative atorvastatin diabetes study was, quote, the debate about whether patients with type 2 diabetes warrant statin therapy should now focus on whether there are any patients with at sufficiently low risk not to be on the drug. So basically, that is the point. So they recommend everyone with type 2 diabetes be on a statin. And a summary, including the heart protective, the Prove It Timmy 22 study, basically, when they lowered their LDL down to 65, they had tremendous improvement. CARD study, again, I mentioned. The VA HIT study used gemfibrozole and was helpful. But basically, the bottom line is, for each 35 milligram decrease in LDL, there's a 50% decrease in CVD in people who have primary prevention, like you and me, if we don't have heart disease. But those who have heart disease, a 25% reduction. And this seems to be consistent no matter what your LDL level is. Are statins enough? Well, it depends. So here's the heart protection study. 40 milligrams of simvastatin reduced risk 24%. But still, that means 1 out of 5 people had an event within the next 5 years. So the question is, should you get the LDL now even lower, down to 70 or less, and that with a higher dose, or like the high dose atorvastatin study, or should you add a second drug? And that's a kind of a question. So the HATS trial looked at niacin-statin, and they had an 85% reduction in angiographic progression in secondary study after 3 years, and 97% event-free at 3 years, published in New England Journal 2001. Now, a more recent study, the AIM-HIGH, is a different study, but the problem with all these new studies is everybody's on a statin. So therefore, if you compare people, the control groups on a statin, there's not that much really difference you can see to find an effect. So we'll talk about, they say LDL should be less than 100 in the diabetic patient. I disagree. It should be less than 70. So in 2006, they came up with an update that said that it might be reasonable drive the LDL down to less than 70 if you can. So there's more data I think I'll show you in a minute about that. But so atherosclerosis, Dr. Guyton showed in this slide, is driven by LDL, reversed by HDL, and modulated by other factors, including the high glycemic obesogenic diet. So here's my favorite character, Homer Simpson. It's healthy eating. And here's a guy with, here's a question for the house staff. Okay, house staff. Which food entree has the worst fat? McDonald's Big Mac, Burger King Whopper with cheese, Arbys bacon, beef, and cheddar, Subway 6-inch meatball marinara, or the Taco Bell salad? Oh, you know this stuff already. Okay. So Big Mac is 46 grams, Burger King is 40 grams for the Whopper, 26 for the beef cheddar, 24. And here's Taco Bell, 52 grams. If that's a salad, I'm the Pope. I mean, it's ridiculous. All right. So, so clearly we talked about how it's an epidemic of obesity, and clearly one of the things in metabolic syndrome is the Western diet that we have today. So the Western diet is not good. Then there's a yo-yoing, people that lose and regain, and one of the things is when you lose about 10% of your body weight, the body's metabolism slows down, so you regain that weight. Some of you might have read recently that Tom Hanks says he has type 2 diabetes, but if you watch him over the years, some movies he had to gain a lot of weight, and some movies he lost a lot of weight, so he's been yo-yoing forever, and he said he's been pre-diabetic, and now his doctor says, congratulations, you graduated, you're diabetic. So yo-yoing is not good. No question, if you want not to die from heart disease, you should be on the Mediterranean diet. It's clearly the healthiest diet, and there have been many studies in it. This is one from Archives in 2008. This is so-called the Predi-Med study, which really, so those in, these were secondary studies, so those who were on the Mediterranean diet plus nuts had a significantly higher 70% chance of reversion. So this study came out this year in the New England Journal using the Mediterranean diet, primary prevention, and the conclusion was, among persons with high CVD risk, a Mediterranean diet supplemented with extra virgin olive oil or nuts reduced incidence of major cardiovascular events. And what does that mean, this diet? Olive oil, nuts, fruits, a lot of antioxidants here, legumes and so forth, some wine, and then discourage sodas, baked goods, fats, and processed meats. So a friend of mine who's a rheumatologist had a lady who was always reading her Bible, and her arthritis was due to the fact she was overweight. And he finally said, have you ever heard of the Bible diet? She said, no. He said, why don't you just eat what's in the Bible? And, basically things that you can grow and whatever, nothing in a package or a can. And she lost 100 pounds in the Bible diet. So it works. There's a lot of things we could talk about, like red yeast rice and soy proteins. And these are things that can help, sterols help, so forth. So then we talk about exercise. Homer Simpson says, why can't someone else just do it for me? And he's sitting there with his donut. All right. This guy was told to walk his dog for exercise. Dog's on the treadmill. So the strategy for diabetic dyslipidemia is first, number one, you still, even though they're diabetic and they have a high non-HDL cholesterol, you still get your most bang for buck by lowering the LDL cholesterol. Then you try to, if you can, raise HDL, which is hard with exercise, weight loss. If you have a high HDL, you're just lucky you have good parents. My mother lived to 9 years old. Her HDL was 80. She never had chest pain in her life. So I mean, that's a great gene. So if you have it, it really helps. Other approaches, again, trying to lower non-HDL cholesterol, ApoB, and then the remnants. So this is another slide courtesy of Dr. Guyton. The best drug to lower LDL, unequivocally statin. The best drug to raise HDL, if you can tolerate, is niacin, followed by weight loss and fibrate. And the best drug to lower triglycerides is a diet, a low-carb diet, absolutely. Weight loss followed by that. And then, of course, you have fish oil, statins, fibrate, and niacin on the bottom. So the NCEP National Cholesterol Education Program needs to be updated, but currently they have a classification of low risk, high risk, and very high risk. Very high risk means you have diabetes or already have coronary disease. And they say, well, get their LDL to 100. And very high risk, you have diabetes and you smoke, or you have diabetes already had a heart attack. And they want their LDL to 70. Again, I want my patients' LDL down to 70 for everybody. I want my LDL below 70. So this shows you the other drugs. And the ezetimibe is not bad for LDL, but doesn't do much for the HDL or triglyceride. Here's niacin here. Actually is pretty good despite that AIM-HIGH study. Bile acid equestrins are hard to take, but they only basically work on LDL. And fibric acids are useful drugs in people that cannot take a statin, or those people that have a high non-HDL cholesterol. So I'm going to summarize this and go into some other slides. We're doing pretty good on time. So I would say, first of all, treat type 2 diabetes as a vascular disease, intervene for early detection, aggressive risk factor reduction in people with abdominal obesity, basically the metabolic syndrome, dyslipidemia, impaired prediabetes, diabetes. So in this country, by the way, there's 25 million diabetics, but there's about 73 million pre-diabetics. So basically, that's almost 40% of the country either has diabetes or pre-diabetes. That is between almost one out of every 3 people. And patients with type 2 diabetes need aspirin, a statin, and try to increase the HDL and decrease triglycerides. Other important summary comments: metabolic syndrome and prediabetes are common. Insulin resistance is a hallmark of the metabolic syndrome. Clues to metabolic syndrome include a positive family history, acanthosis, and Caucasian people, they may have some acanthosis under the arms and never get in the neck, but minority people have it in the neck. And if I see someone who looks Caucasian, they have it in the neck, I ask, do you have any Native American? Sure enough, they have Native American in them. So you have to look in the neck. So to look at the neck, look at the underarms, you have to examine the patient to look for the acanthosis and for the skin tags. And skin tags are equivalent to acanthosis. Prediabetes is associated with twofold cardiovascular risk. Dyslipidemia should be aggressively treated with statin or other drugs. And lifestyle is still the preferred method. So in the diabetes prevention trial, they compared active lifestyle, which is significant dietary intervention, and physical activity versus metformin or TZD. And actually that won. The lifestyle reduced conversion from prediabetes to diabetes. And so doing the same, you're also going to reduce their cardiovascular risk. We talked about LDL goals. I'm not going to mention novel risk factors like CRP, but I'll be glad to take questions about that. So in treatment of dyslipidemias, I want to mention that statins have a pleiotropic effect. And there's some data that maybe we should actually lower the LDL down to even 50. Yeah, I know. Well, so really, because it's true that vegetarians and chimpanzees, like I mentioned, have LDLs well below 70. So, and some people say, well, it's not the statin, but it's these pleiotropic effects that make the difference, and that may be true, because statins stabilize plaques. It's very important that statins help stabilize plaques, and that's why they can prevent heart attacks. And there was one study that came out of Korea in 2011, which basically showed that patients who had an LDL below 70, who went on a statin, had significant less events in the next year than those who had below 70 did not go on a statin. So here are people, LDL below 70, had a heart attack already. And when they were on a statin, they had significantly less reduced. So it's either because it's reducing the LDL below 70 to 50, or it's because of these pleiotropic concepts that the statin can do. It has these, so it's not all cholesterol lowering, it does other things as well. So here's something interesting. The Japanese eat less fat than us, they have fewer heart attacks. Mexicans eat a lot of fat, they have fewer heart attacks. Chinese drink very little red wine, they still have fewer heart attacks than Americans. Italians drink a lot of red wine, they have less heart attacks than Americans. Germans drink a lot of beer, eat a lot of Wiener Schnitzel, and still have fewer heart attacks. So conclusion, eat and drink what you want. Speaking English is apparently what kills you. So we had some time. I have some other slides. The fellows have probably seen this already. But I want to mention endothelial dysfunction. It's very, very important to note that the endothelium lines the vessels, and if it's abnormal, it can cause a problem. So here is LDL, and as I mentioned, it's oxidized. The small LDL is oxidized, causes fatty streaks, plaques, rupture, and thrombosis. But oxidized LDL also causes inflammation. And again, statins can work to decrease inflammation here. And LDL oxidized also causes endothelial dysfunction, and statins also work here to prevent that. So that's important. So what is endothelial dysfunction, and how do you measure it? Well, we know, for example, if you have normal endothelium, that promotes vasodilatation through nitric oxide, thrombolysis, platelet disaggregation, growth inhibition, and lipolysis. Where dysfunctional endothelium causes vasoconstriction, thrombosis, adhesion molecules, growth factors, apoptosis, inflammation with cytokines. So it's very important to know that you want to regulate that. So one of the ways you can measure it is using something called the forearm test, forearm blood flow, FBF. So if you take a blood pressure cuff and you use you do an ultrasound, you can see this brachial artery has a diameter of 3.1 millimeters. Then you blow up the blood pressure cuff for 5 minutes. Patient says, "Ow, that hurts." Of course, anyway. Then you release it, and now when you measure, you do a measurement here. The diameter of the brachial artery is 3.6 millimeters. So this is actually called flow-mediated vasodilatation. Or post-occlusion. So 1 minute after releasing the cuff, it compensates by dilating. So we have this ability when we're young. As we get older, we lose this ability. The vessels become thick and calcified, and I actually am a believer that for patients, you're worried about their risk, you should actually send them over to the heart center and get the calcium CT scan, because it's very helpful, and it only costs $50 because insurance does not pay for it. And I think it's very helpful for people in risk to try to decide, that I think I would advocate doing that in some high-risk patients as well as doing the NMR profile. So you can see that, therefore, this mediation thing goes down in men when they're about 45 or 50, and women down, not diabetic women, but non-diabetic women around 50 or 60. So we can do things to improve our endothelium. So if you go out for a walk and you walk for about a half an hour, and then 1 hour later, after your walk, you can see your endothelium is improved. Likewise, you go to Bojangles and you make it worse. This is a study from many years ago, but it's very worthwhile. Look at endothelium after a big meal of Egg McMuffin, sausage McMuffin, and 2 hash browns. I have patients like that every day. And you see that looking at the brachial artery flow-mediated vasodilatation, it takes about 5 hours to get back to normal after eating that meal. So maybe you don't want to go there tomorrow. And a cigarette, this is an interesting study looking after a cigarette. So you can see how immediately how it goes down as you smoke that cigarette. But it takes 90 minutes to get back to normal. So you do the math, looks like each cigarette shortens your life from cardiovascular disease by about 11 minutes. So you're doing 2 packs a day. Hope you have good life insurance. So stress is also bad. It's a study where they actually stress people out, and they found under stress, they rechecked after stress, and in fact, they also had endothelial dysfunction. On the other hand, humor is good. This was a study done by Dr. Vogel in Baltimore many years ago when Saturday Night Live was actually pretty funny. And the people watched Saturday Night Live, and their endothelium improved. They did another study more recently where people watched either a comedy or a movie that was a comedy or one that was really sad. And the ones that watched the comedy, they went up. So I tell my wife, I only want to watch comedies from Netflix because I want to improve my life. So it's important. It's also important to laugh. I'm trying to make you laugh in this talk. So this is a bonus from this lecture that is at no charge for you to laugh. So some other lifestyle risk factors to think about. Alcohol. You should know men consume twice as much than women. And there is some effect. And you know, the French paradox with the French people drink a lot of wine. They eat all that high-fat food, but they seem to have less heart disease, as you already mentioned. So you can drink a little bit of alcohol. Maybe red wine is fine, but too much is not good. You can also get a DWI for drinking too much. So we would just say limit your alcohol. So that would be about 40 grams for men and about 20 grams for women. I love this one. It's a study came out a few years ago on chocolate and the Stockholm epidemiology, the sheep study. It turns out that people that had chocolate had lower mortalities after a heart attack. So if your chest starts to hurt, pop an aspirin, have some chocolate on the chocolate on the way to the emergency room and the ambulance. This is a study of statins showing from Dr. Vogel again that this was cardiologists. These professors of cardiology had their endothelial function checked before and after they went on statins, and there was a marked, whether they took pravastatin or simvastatin, there was a marked improvement in LDL and in flow-mediated vasodilatation. Here's a question for the audience. Which occupation is most stressful? Chicago bus driver, Greenville policeman, school medicine physician, North Carolina park ranger, or cashier at Walmart? Of course. So here's the forest ranger. He has the lowest job strain and the lowest decision latitude. So he goes onto the tower with his binoculars, and it's sunny out, and it's a beautiful day, and there's birds, and there's very low stress. And, you know, and his whole thing is all he has to do is, you know, take the binoculars, smoke in Sector 6 and call it in. That's all he has to do. So he has a good job. So how about physicians? Well, we're not quite as good. It probably depends what you do, whether you're a surgeon or psychiatrist, whatever. So here are the people with the highest stress jobs: assembly line workers, cashiers, even waiters sometimes have And it has to do with your psychological demands and the schism latitude. So really, it makes a difference. So this is an interesting thing. You take men and women who are in routine occupation, and you promote the woman, so she's now in a prestige occupation, she's a dean maybe, and her risk goes up, actually, from triples her risk for heart disease. The man, you promote him, and his goes in half. Doesn't seem fair? Don't shoot the messenger. However, if the woman takes the job and the man stays home, he doesn't do as well. So the house dad, his goes up, and if she leaves him and he's divorced, his goes up as well. But occupation is stress and makes a big difference. So it is important what you do if your life is stressful or not. As I've gotten older, I've tried to make my life as least stressful as possible. I used to be in D.C. and spend 45 minutes each way commuting back and forth. Now I get here in 6 minutes, so that makes it a lot less stress. So Dr. Vogel gave me this slide. He called it the virtual blonde effect. My wife's a blonde. She said that was sexist, so I named it the happy marriage effect. So it turns out if you cohabitate or are married with someone that makes you happy, you really do much, much better. Your quality of life is with survival in heart failure subjects than with someone that makes you unhappy. So my advice, if your spouse makes you unhappy, you should divorce them. This is a problem if you have kids. Kids are not good. So you see this is effect on kids and pets. 1 more year mortality after a heart attack. And you see people with kids definitely had a much increased risk. So the first kid's worse, second kid's not so bad. I don't know about 8 kids, I don't know. But so if you already have kids and they're under 18, what can you do? Then you go out buying a dog because a pet actually reduces your mortality. So some of you people say, what about cats? Well, it turns out dogs are better than cats. Sorry, cat lovers. Well, you think about it. You have a dog. All the dog wants is to be petted and have to feed them, and they really are pleasant, and they make you happy. They give unconditional love. A cat is smart. They get what they want, and that's it. So in a way, dogs are probably better. Plus, if you have a dog and you walk the dog, not with your car, but you get out and walk the dog, that may be helpful too. So in this thing, it's better. So if we put this together, my advice to all of you is don't worry, be happy, drink in moderation, eat chocolate twice a week, limit trips to McDonald's, Krispy Kreme, and Bojangles, be successful in your career, whatever it is, marry or cohabitate with a fun person, exercise 3 times a week, don't smoke, have lots of friends and dogs, but fewer kids and cats. If you can't do that, then take a statin, aspirin, and get a good cardiologist. Thank you very much. Do we have any questions? See, I made your day, and I improved your endothelium today, so you should be happy. Dr. Drake?
Yeah, I got a question. So when you have your diabetic patient who's perhaps had some vascular disease in the past, and you're trying to fairly aggressively lower their LDL cholesterol, you got them on the maximum dose of statin they'll tolerate, and they're following a decent diet, been through dietitians and so forth, and their triglycerides and HDL aren't crazy out of line.
And they're on a statin. Well, again, you try to see what dose of statin they're on. So, they took the 80 milligram simvastatin off the market because of problems, but they do have high dose of atorvastatin. Rosuvastatin is even more powerful. So you can try to give the most powerful statin they can tolerate. That will lower the LDL. And then I think if their non-HDL is high, they're still at risk, and you can do that. You can do the NMR. If you're really worried, you can go and send them for the coronary calcification study, Dr. Mavahed. And you're still at high risk, then you have to say, okay, what am I going to add? If you add ezetimibe, their studies showed ezetimibe plus either atorvastatin or simvastatin lowers LDL more and may have some benefit, or you can then try to deal with things like niacin fibrates. Unfortunately, niacin is poorly tolerated a lot. Some of the fibrates depend, so the gemfibrozole is the cheapest one, but that has interactions with things like simvastatin. So pravastatin is a good one. There's no drug interaction with that one. So I think there are other options, but I think, part of it is nutrition. I mean, what happened in this country is they said we need to have low fat. So all the companies took the fat out of a lot of products, and instead they put in more carbohydrates. And in fact, our country's getting fatter. And people that go on low carbohydrate diets, their lipids improve a lot. So, I mean, I say any diet that works is a diet worth keeping, and I encourage people to do. But I think the low-fat diets have really not been successful. It's hard to follow. They're not really successful. So if you want to prevent heart disease, Mediterranean diet is better. If you're trying to lose weight, a low-carb diet's good, but it's hard to go for 4 weeks without eating a bagel or something like that. So it's difficult to stay on a low-carb diet. Some people can. But I think anything that can help them lose weight. And the other point is, it's very important, you go on the diet and you lose weight, you must exercise. Otherwise, the weight will guarantee it's going to come back. It comes back every time. Great question. Yes, in the back?
What do you say about fish oil capsules? Because, I've read studies recently where they're saying it doesn't help the liver.
Right. So, that has been a some concern, as even some say, well, the fish oil capsules have to do with prostate cancer. I don't know. I think, the best you can do is you measure your lipids. Patient can't tolerate this, they can't tolerate that, and you put them on fish oil and they improve, then great. But actually, probably what's better than fish oil is really eating fish. And those things like salmon are really worthwhile. I happen to like fish. Some people don't like fish, but if you eat a lot of fish, that's part of that Mediterranean diet. It's probably healthier to eat the salmon or sardines during the week than it is, sardines are probably a lot cheaper than fish oil capsules, especially if you get the commercial one. So I don't know, but I think that a lot of these things have to be relooked at. Some people are saying that saturated fat's not as bad as we think it is, but clearly I think the point of the matter is we were meant to be vegetarians. The fact that we can eat meat clearly as a survival mechanism. But, and so what I do in our home is we get the leanest meat possible, and I don't think it helps that these cows, in addition to being fed all the corn, are given antibiotics and hormones. I think that's a terrible thing. We've been eating this stuff for years, and that affects our kids, it affects everybody. So I think, we're really a victim of what we've done in this country, and it's really unfortunate. Because really, you have a patient who's on their statin or whatever, and then they go away for a vacation for a week, they come back, their livers are terrible. It doesn't take long. I've had people go on a cruise, they come back and all the lips are bad, because this changes very quickly when you start changing your diet. So it's really important to eat properly, because no matter what you take for your cholesterol, if you don't eat properly, you'll never do well. Okay, I'll be around with more questions. Thanks again.